Hi, this is Chris Meduri from the Piedmont Heart Institute, and it's my pleasure to be here today with Dr. Gorav Ailawadi as well as Dr. Paul Sorajja, and we're talking about the tricuspid space. And specifically, guys, I want to ask you, right now in our patient clinics, when we actually get a TR patient that referred to us, they're typically at the end of the disease process. So ascites, bad lower extreme edema, maybe some signs of liver dysfunction, and I think we all agree that's probably not who we want to be treating downstream. Where do you think, maybe not today, but in the next few years, knowing the new technologies on board, do you think we're really going to be trying to target treating these patients?
Well, I think it's going to follow the analogy of surgery. We're going to find that earlier is better than later, and before RV dysfunction is better than waiting until RV dysfunction. I think we're going to find that the horse is already out of the barn by the time somebody becomes symptomatic or the RVs enlarge. And I hope that the future technologies will have a safety profile that will now allow us to do the prophylactic repairs that we need to do. And without that, it's just going to be really hard. We all know it's going to start in the high prohibitive risk patients with a certain amount of RV failure, but we have to move towards a prophylactic approach. Otherwise, I just don't know how much of an impact we're going to have on these patients' outcomes.
And Gorav, yeah, I mean, I have to say I agree completely with Paul. I think that's going to be the paradigm shift to treating patients earlier. The challenge is going to be we're doing a technology that try to do a study that shows benefit. That's going to take years, but we all probably agree. We think that early treatment is probably the most effective thing. How do you think we're going to be able to approach that challenge of effectively showing that we need to treat these patients very early and getting our colleagues on board with that as well?
Yeah, well, I think that the first question is it really gets to these trials that we're doing. What should we really be studying as the endpoints? And that's been a heated debate. As you may know, we have an NIH-sponsored network called the CTSN, and one of the trials we're focusing on is patients with concomitant tricuspid valve disease, whether when they're undergoing mitral operations. And these are in patients that don't even have severe tricuspid regurgitation. It's a randomized trial. And one of the heated discussion points is what the endpoint should be. And it can vary, as you know, from severity of TR, which can be quite variable day to day based on the fluid status. Mortality, that's certainly an important endpoint, but doesn't happen necessarily always in the short term. And I think we also need to probably get smarter about using imaging criteria to look at RV function as an endpoint. And I think that's where that may be a more real link to help us identify outcomes before a true clinical endpoint is met.
No, that's great. So I think in summary, you guys are exactly right. Of my consensus kind of feeling and talking to others as well, that right now we're having to treat the later stage people, but I think the ideal cohort of patients is going to be a much earlier treated population, probably even asymptomatic, and we're trying to stop a disease process we know has a lot of morbidity and mortality before we get to that point. And there'll be challenging clinical trial endpoints, and I think you're right that the degree of RV dysfunction and some other surrogate markers, maybe more so than hard clinical endpoints, because we're treating asymptomatic patients, are highly relevant. And so we'll have to work well with the industry and with the FDA to try to figure out what those points are. But I think these are really interesting things we hope to learn about in the next few years. Yeah. Great. Well, thanks for listening to us, and hopefully we can keep talking about TR more in the future.